Hey guys, I'm going to post a quick video to cover nausea and vomiting, really more of a focus on chemo-induced nausea and vomiting. And then that'll go ahead and finish the GI information that's going to be on this exam, on exam 2. I will then continue on with diarrhea and constipation, and then that will go ahead and be on the following exam. So this quick video is the last part of exam 2. Chemo-induced nausea and vomiting. I think we're all pretty well aware that chemotherapy causes a lot of nausea and vomiting. That's one of the side effects that really makes this the most miserable for cancer patients. Chemo-induced nausea and vomiting, and really nausea and vomiting in general, are typically worse in the young and worse in women. Chemo-induced nausea and vomiting occurs in between 70 and 80% of chemo patients. There's also something called anticipatory vomiting, and that's just like it sounds, vomiting that occurs in anticipation of the actual chemotherapy. So this can be anything from like the routine that the person does before chemo, to the actual seeing the chemo, smelling the chemo, and this is just a learned response that the body has. And anticipatory vomiting, which has an anxiety component to it, occurs in between 10% and 40% of patients. Now, obviously, the vomiting differs depending on the chemo agents that are being used, depending on the chemo regimen, as well as the patient themselves. At the end of this, the presentation, I will show you guys a chart that has common chemo meds, and it has their kind of classification as far as their emetogenic potential, like how likely are they to cause emesis or vomiting. But different agents do have a different likelihood of causing vomiting. Nausea and vomiting is obviously miserable, absolutely miserable, and really decreases quality of life in patients who are receiving chemotherapy, or patients who have intractable vomiting for another reason. But there are actual physical problems as well. It's associated with dehydration, so making sure that the patient's got fluids is important. It can be associated with metabolic disturbances, nutrient depletion if it's for an extended period of time. And then again, because there's such a decrease in quality of life, it can lead to the avoidance of chemotherapy, and just a flat refusal to get the chemotherapy in patients who are experiencing rather severe nausea and vomiting associated with their chemo. So there are a couple different mechanisms that induce nausea and vomiting. There are two different centers in the brain, or two different areas of the brain, that can stimulate the vomiting reflex. One of these is the chemoreceptor trigger zone, or the CTZ, a chemoreceptor trigger zone. Named aptly because this is the area where chemotherapy typically stimulates the vomiting reflex. Now, it's not just chemotherapy that can do this. Other agents that cause nausea and vomiting can also bind in the CTZ and cause it. But chemo is just really apt to do this, hence we call it the chemoreceptor trigger zone. The chemoreceptor trigger zone is at the caudal end of the fourth ventricle, so like towards caudal tail end of the fourth ventricle. Because of the location of the chemoreceptor trigger zone, it's actually located outside of the blood-brain barrier, meaning it can respond to, or it can be stimulated by, any chemical that's going through general circulation. If it were located actually inside the blood-brain barrier, then it would be protected from a lot of different compounds, right? Not all drugs cross into the CSF. Not all drugs cross the blood-brain barrier. But because of its location, because it's not enclosed in a blood-brain barrier, any compound that's traveling through general circulation can also access the chemoreceptor trigger zone and can stimulate it. And when the chemoreceptor trigger zone is stimulated, it induces the vomiting reflex. The vomiting center is located in the brainstem. It's in the reticular formation, specifically in the medulla oblongata. The vomiting center coordinates the mechanics of vomiting. So it sends out the signals, to the stomach to contract, to the lower esophageal reflex to relax and open, just coordinates the whole response, so makes the actual vomiting happen. Now, the vomiting center does respond to multiple other stimuli as well. So stimulating the chemoreceptor trigger zone will stimulate vomiting, and stimulation of the vomiting center will stimulate vomiting. Now, the vomiting center receives sensory stimulation from multiple different areas. It receives sensory information from receptors that are present in the pharynx and in the GI tract. It responds to multiple cortical structures. So this is where like anticipatory vomiting would come in, right? The memory of what's about to happen, the anxiety from the cortex starts to kick in, and that sends information to the vomiting center. Mostly though, most frequently what the vomiting center responds to is the vestibular system. So it's the vomiting center that's typically involved in motion sickness. So motion sickness stimulates there's a lot of stimulation in the vestibular system, and then that stimulates the vomiting center. And then again, for our purposes of chemo-induced nausea and vomiting, the vomiting center is involved in anticipatory vomiting, whereas the CTZ is typically the vomiting from the actual chemo agents themselves. Okay, again, the actual way that these chemo agents or anything really causes nausea and vomiting, we said was by triggering either the chemoreceptor trigger zone or the vomiting center. Now, the actual agents, the compounds that are used to stimulate these areas include dopamine and serotonin when we're looking at the chemoreceptor trigger zone. And there are various other compounds that stimulate these centers, like substance P, for example, we'll look at when we look at the vomiting center. But there are numerous compounds that do this. The most important of these that we'll look at include dopamine and serotonin. The chemoreceptor trigger zone is stimulated when dopamine binds to dopamine 2 receptors, and when serotonin binds to 5-HT3 receptors. Okay, again, we do have substance P, for example, that can stimulate the vomiting center, but because the vomiting center is receiving stimulus from a lot of different areas, it's not just substance P. It receives substance P, it receives serotonin, it receives a lot of different input. So compounds that are actually in the bloodstream, traveling through the bloodstream, can end up stimulating the chemoreceptor trigger zone. Sensory input can induce vomiting via the vomiting center. So we said color, smell, routine, right? The habits, the things that happen as you're leading up to the chemotherapy. Taste, any of that can activate higher brain centers to induce vomiting via the vomiting center. This is where that anticipatory vomiting comes in. So say you have the same routine, the same things happen every time before you go get chemo, that can actually induce anticipatory vomiting. Also, actual physical damage to the GI tract can induce vomiting. The peripheral damage to the lining of the GI tract releases serotonin, from the enterochromaffin cells. That serotonin then binds to receptors on the afferent fibers that are going back to the central nervous system, and that can send sensory signals up to the medulla, to the vomiting center, to stimulate vomiting. Okay, so there's the actual leading up to the chemotherapy can cause anticipatory vomiting. The actual chemotherapy itself being in the bloodstream can cause vomiting. And then after that infusion, when the chemotherapy is intracellular and when it's working, the actual damage to cells that it causes can then actually induce further vomiting, which we call delayed vomiting. So there's multiple different phases of vomiting that can occur, depending on which phase you're in or what part of the body you're in. Different receptors are involved. We have found, though, that dopamine receptors are important, and these 5-HT3 receptors, serotonin receptors, are very important. All right, so we'll talk about different antiemetic drugs that we use in chemo-induced nausea and vomiting. Note, there are other drugs that we use for nausea, like for motion sickness, that we're not going to really focus on here. So we talked about before the anticholinergic scopolamine. That's an N, scopolamine. There's also an H1 antagonist or an H1 blocker called meclizine. And these are really effective for motion sickness, but they do not work at the chemoreceptor trigger zone. So we do not use them for chemo-induced nausea and vomiting. For chemo-induced nausea and vomiting, there is involvement of the vomiting center. So we do want things to work at the vomiting center, or that can be helpful, but really we're focusing on the chemoreceptor trigger zone for chemo-induced nausea and vomiting. So these, again, scopolamine, meclizine, great for motion sickness, however, not great for chemo-induced nausea and vomiting. All right, so we'll start with our most effective agents, which are the 5-HT3 antagonists or serotonin antagonists, 5-HT3 receptor blockers. Any of those names are fine. These agents include granisetron, ondansetron, which ondansetron is Zofran. That was like kind of the original, probably the most frequently used agent. Pelonosetron, right? There are a couple others as well. They all end in cetron. So that kind of gives it away. But again, ondansetron is typically the most frequently used. It's available in generic now, relatively inexpensive. These agents selectively block 5-HT3 receptors in the periphery and in the chemoreceptor trigger zone. Their selectivity is good. It allows us to treat the chemo-induced nausea and vomiting, or just nausea and vomiting in general, without having other psychological side effects. They have much greater efficacy than really any of the other agents that we have. They've really changed the game when it comes to chemo-induced nausea and vomiting. Much greater efficacy, and they typically have a relatively long duration compared to some other agents, so it really makes them good in chemo-induced nausea and vomiting. Frequently, we can do a single dose prior to chemo in order to prevent the nausea and vomiting during that episode, and they are effective for all emetogenic potentials. Again, I told you guys that we rank chemo agents based on their potential to cause nausea and vomiting, and some agents are only effective for low or moderate. These are effective all the way across the board. We do use them for other indications as well. We use them in the post-operative setting to prevent post-operative nausea and vomiting as the patient's coming out of anesthesia. I have seen them used in pregnancy. Now, it's not the first line agent that you would go to. There's a lot of other stuff that you would go to first, starting with like vitamin B supplementation. So there's a whole list of other agents that can be tried first in pregnancy. But if the nausea and vomiting just cannot be controlled, and it's to the point where the patient's suffering from dehydration, or they're not able to keep food down, and you've got weight loss happening, at that point they can be used in pregnancy as well. So there are a lot of different indications, but they are incredibly efficacious. So we see that they work really well, even with the worst of the emetogenic chemo agents. Come in multiple different formulations. A solution and oral tablet are both available. Intravenous formulation is also available. Now, with nausea and vomiting, it is best to prevent as opposed to treat. So prophylactic use is always best, hence the fact that we typically will give it prior to chemo. We don't wait until the person's actually throwing up in order to give the serotonin blocker. However, if the patient is already throwing up, obviously taking something by mouth that needs to be absorbed from the GI tract isn't going to work, because they're likely going to just throw up the drug. In that case, IV can be used, but also we can do a sublingual tablet or a film that just dissolves in the mouth. Remember that as the sublingual tablet or the film dissolves in the mouth, it's just getting absorbed right into the bloodstream across the oral mucosa. So it's going in the mouth, but they're not actually getting it from the GI tract. So in that case, the patient is okay, as long as it can dissolve in the mouth without them throwing up. Then that formulation allows you to avoid the GI tract, to take the medication even though they're vomiting, and then to not have to give something IV. One thing to keep in mind with ondansetron is that it is highly metabolized, and dose modification is necessary in hepatic insufficiency. And also that ondansetron can be associated with QT prolongation at high doses. So if this was being used, for post-operative nausea and vomiting, or something where you're giving a low dose short period of time, you're probably not going to see this. But if you have somebody who's got high emetogenic potential chemotherapy, where you're giving a really high dose of ondansetron for regular periods of time, then that is something to keep in mind, that it is possible. Okay, see a couple other agents here. Phenothiazines, prochlorperazine. Prochlorperazine is a dopamine receptor blocker. So we said that both serotonin and dopamine were involved in stimulating the chemoreceptor trigger zone. So prochlorperazine blocks those dopamine receptors in the CTZ, and it has kind of middle of the line efficacy. It's used with low or moderate emetogenic agents, so it's not as efficacious as the 5-HT3 blockers. Also, because it's blocking dopamine receptors, dopamine is associated with a lot of other adverse drug effects, whether we have too much dopamine and we have psychotic symptoms, or whether we don't have enough dopamine and we have movement issues. In this case, it would be movement issues. So adverse effects tend to be dose limiting with prochlorperazine. Metoclopramide, similar in the fact that metoclopramide also inhibits the action of dopamine in the chemoreceptor trigger zone. Again, moderate efficacy. It's not as efficacious as the 5-HT3 antagonists. When we talk about its efficacy or how well it works, metoclopramide prevents emesis, so completely prevents it, in about a third of patients on cisplatin. And cisplatin is really high emetogenic potential. So in patients who are really, really likely to have severe vomiting, it prevents the vomiting in about a third of those patients. Now it reduces the vomiting in all of those patients. So it does have some efficacy, but it's not as efficacious as the serotonin blockers. Now, again, though, because we're dealing with dopamine here, and because it's not as specific, we do have adverse drug effects that limit its use. And these adverse drug effects are the extrapyramidal symptoms. So again, movement issues because of the blockage of dopamine. We do use metoclopramide also to stimulate gastric motility in gastroparesis. Corticosteroids can also be used for nausea and vomiting. Specifically, typically use dexamethasone or methylprednisolone. When these are used alone, they have kind of a moderate efficacy, but what we typically do, we'll use them in combination with other agents. So for example, we can use them in combination with a 5-HT3 antagonist. And this makes sense, right? If you think about the fact that there's all different types of vomiting. There's anticipatory vomiting. There's, your actual vomiting that's occurring, with the chemo and right after the chemo. There's also delayed onset vomiting that can occur because of the actual, damage that's occurring from the chemotherapy. So because there's all different types of vomiting, and because remember, vomiting is occurring in multiple areas. It's occurring because of actions in the CTZ. It's occurring because of actions in the vomiting center. So because of this, it's helpful to use multiple different agents that are working in multiple different ways. And this typically gives us the best response. So while corticosteroids aren't super effective on their own, they do provide additional efficacy when they're combined with other agents. That's the same thing for benzodiazepines. Benzodiazepines like alprazolam or lorazepam. We'll talk about those more when we do mental health, because that's what these agents are typically used for. These are anti-anxiety medications. Now, they have a low antiemetogenic potential on their own. However, because they have anxiolytic effects and because they have sedative effects, we do find that they can be helpful in chemo-induced nausea and vomiting, specifically or especially in anticipatory nausea and vomiting, where there is that cortical input, that level of anxiety that's leading to the nausea and vomiting. But again, would we give those alone? No, they would be part of an overall treatment approach for the nausea and vomiting. Other agents include neurokinin-1 antagonists, or we also call them substance P antagonists. Substance P binds to the neurokinin-1 receptor. So you can kind of title them either way. But neurokinin-1 antagonists include aprepitant. Getting rid of this P here. Aprepitant, nutepitant, rolapitant. These agents all, again, block substance P from binding to neurokinin receptors in the vomiting center. So this is a little different, right? When we look at the serotonin blockers, when we looked at the dopamine blockers, we were looking at what was happening in the chemoreceptor trigger zone. So now we're looking at what's happening in the vomiting center. And these neurokinin antagonists are typically for moderate to high emetogenic agents. So again, good, solid efficacy with these agents. Now, because these are targeting the vomiting center as opposed to the the chemoreceptor trigger zone, we typically will give these in conjunction with other agents because we also want to target the chemoreceptor trigger zone. So these are commonly given in conjunction with serotonin antagonists and then also dexamethasone. These are effective are especially effective for the delayed phase of chemo-induced nausea and vomiting, which makes sense because, again, that's where the vomiting center would come in, right? While the drug is actually flowing through the bloodstream, it's going to be stimulating the chemoreceptor trigger zone. However, after the drug has been in the system and it's intracellular and it's actually having its effects, remember we said that the drugs can damage the lining of the GI tract. And then that actual damage to the GI tract causes input to the vomiting center, and then there's delayed vomiting. So targeting the vomiting center would be effective for preventing this delayed phase of chemo-induced nausea and vomiting. There are many drug interactions, though, that occur with these agents, so that's something to keep in mind. There are already a lot of interactions that happen with chemo agents anyways, and patients who are on chemo typically have a lot of medications on board. So I don't expect that you guys memorize the specific interactions, but just keep in mind that there are interactions. So that's something that you need to look into. Also, adverse drug effects include fatigue, diarrhea, abdominal pain, and hiccups. Okay, so this is just kind of FYI. Over here, we have the relative antiemetic activity of the different classes of drugs. Now I have here, you see phenothiazines, substituted benzamide. These are like metoclopramide, right? Those are those drugs that we looked at the beginning that block dopamine receptors or block dopamine activity. Now here you see that they have high antiemetic activity, but I told you guys that they have moderate. And the reason for this is that it is almost impossible. It's really hard to get to high enough doses to have this high antiemetic activity. Because of the side effects that come from blocking the action of dopamine, you just can't get to a high enough dose. That's why I've kind of crossed these out here, is that really those belong down here. Because you're not going to be able to give enough of the drug to get that high antiemetic activity. Which means our serotonin antagonists, our 5-HT3 blockers, are really up there, as well as, it's not listed on this chart, but the substance P, or neurokinin 1, antagonists are also highly effective. And then the other agents kind of go down from there. But we'll typically use a combination, and that's what you see over here in the second picture. Over here we have different common drug combinations that are used, and then you see the response rate. So dexamethasone and ondansetron, highly effective. And then different combinations as we go down. Notice as we go down, we're adding more drugs, but we have less efficacy, right? So there's 4 drugs here, 3, but the efficacy is going, the efficacy is lower and lower and lower. The reason for that is, if you notice, look at the drugs, there's no serotonin antagonist in any of those combinations. So if for whatever patient reasons you had to avoid a serotonin antagonist, there are other combinations that you can use, but they are much less effective. That serotonin antagonist, I told you guys, really changed the game. It really increased the efficacy of our antiemetic combos. Okay, all right, that is it for chemo-induced nausea and vomiting. If you guys have any questions at all, please feel free to shoot me an email, and I'll see you on Friday.